I'm kind of going through the slides here. Okay, a hospital nurse works collaboratively with a primary care provider, social worker, physical therapist, and home health care nurse to provide nursing care for a patient following an MVA. So MVA is a motor vehicle accident. They no longer call it an accident, right? Oops, I hit your car. Right, it's a collision, MVC. Okay, what should the central focus of this care be?
The patient.
It's the patient. It's always the patient. Everything is patient-centered, patient-focused. Okay? I don't care what the agenda the nurse has or the doctor has or the physical therapist thinks. It's the patient. Everything is always the patient. So if you have a choice on the test that gives you a choice about the patient, it's the patient. Okay? CUSIN competencies will not be on there. Oh, sorry. Okay, here you go. Page 7, slide number 13. Hint, hint, hint. The 4 nurses' aims.
Promote health, prevent illness, restore health, and facilitate coping with disability or death.
So promoting health, we prevent illness, we help restore health, and we facilitate coping with disability and death. Those are the 4 aims of nursing, okay? What I want you guys to be able to do is take promote health. How do you as a nurse promote health? What can you do as a nurse to promote health? Education. Good. So prevent illness. Education. Vaccines, hand hygiene, right? Restore health. What? Absolutely. Everything's patient-centered when you're restoring health. Individualized patient care, because what works for one patient is not going to work for another, right? Facilitate coping with disability or death. That's a tough one, okay? Has anyone had to kind of facilitate a conversation with a family that's experiencing disability or death? It sucks, okay?
I've been a family member.
I think that's the worst part of our job. And especially once you're in nursing now. You guys are nurses, right? You're student nurses. Now that you're nurses, family and friends are going to be relying on you more and more and more to kind of pick your brain about stuff. And it's very difficult when that's a friend or a family member, because you just want to be that friend or family member. You don't want to be the nurse at that moment, right? So when you're facilitating coping with disability or death, let's say that you had a family member who had a stroke, okay, and they were in the hospital. They were doing okay, and they were gonna have to go, they need 24-hour care. And family's like, oh, you're a nurse, you can take care of them. I'm just gonna move grandma into your house. What do you think that does to the relationship between granddaughter who's a nurse? That like strains that relationship, right? I actually encountered that when they're like, oh, you could take care of granddad, blah, 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 you're a nurse. And I was told by like my colleagues, they're like, don't do it. Don't do it. It will destroy your relationship. Because you're the mean person who's giving them meds. You're the mean person who's making them do this, who's telling them what to do all the time. And it totally strained the relationship between granddaughter and nurse. So facilitating coping, I'm not telling you to tell the patients and family members what to do, but sit down and talk with them. Tell me what you understand about this illness. Ask them, pose the question back to them. Tell me what your understanding is. And they'll say, I don't know anything about it. And then you could then facilitate a conversation. Would you like me to get social work to help you? You know, if they need a chaplain when they're dealing with disability or death, especially if it's unexpected. I'm sure the ones who have worked in a hospital in this room have called the operator to get a chaplain to the bedside to read last rites, or to help support a family member that was having a hard time, or even the patient, right? When the patient's not doing so well and they're just like, I need to pray, you know? I shouldn't say this. I'm a spiritual person, right? I don't go to church, but I am a spiritual person. And I had a devout Catholic patient who wanted me to pray by his bedside with him. Okay? What would you do in that situation? Would you like pull up a chair and sit with him?
Yeah.
Regardless if you have the same beliefs as them, you sit down, you hold their hand if they want to hold your hand. Put your head down, you put your head down.
You're not being asked to join the faith, you're being
No.
asked to comfort.
You're supporting your patient. Okay, that's it. You know, the first time I was asked to do that, I think I was like 21 and a nurse, and I was like, oh, what is, you know, I wasn't very attuned to my surroundings, if you will. But I get it now, right? The family just wants that support. The patient just wants to know that you're there for them, and that's all that matters in that moment. Office Depot's got to be texting me. Okay. Sorry. All right. So when we facilitate coping with disability or death, that could be getting resources to the patient and the family. So calling social work, chaplain, you know, maybe they're disabled and they can't afford their medication that the doctor just prescribed them. Patient comes into the ER, new diagnosis of diabetes, and guess what? Do they have money to pay for the glucometer and the insulin? You know, my dad, who's on Medicare or whatever it is, had to go buy his insulin at Kaiser the other day for $275 a month. It's nice because he can afford it, but what about the people that can't, right? And so if you have a patient who has to feed their children or take their medicine, guess what? They're feeding their kids before they take care of themselves. So when you're facilitating these things, make sure you're letting the team know what's going on. So you're letting your charge nurse know, hey, I'd like to call the social worker because of this. Let the pharmacy know. You know, is there an off-label medication that is the same? You know, generic brand, that's an on formulary maybe. Okay. All right. So that slide, no, that slide.
Can I ask a question?
Yes.
But I'm confused about, like, I know that, like, the QSN is not part of it, but you have this in the slides, you have the definition of a nurse, and then the QSCN competencies, the nurses and the 4 blended competencies. So, like, the part that I'm confused of is, like, if you were to map them out, like, how they link together, I don't really understand, like, how, like, which one goes into which umbrella, like, how they
They all intertwine.
Like, how? Could you, like, if you were to...
Nurses' aims are super general, we're talking about what we're doing generally to keep our patients safe and respected and.
It's very gray.
But then your 4 blended competencies are how you do it.
How do you do that?
Are you applying it? Are you using technology? Are you technically applying
So
it?
your aim is to promote health. I may do this by
The 4 blended is the how.
cognitive, by asking them what they understand about the condition of the
And the
patient.
nursing aims are for
Right?
that patient.
So,
How is it understand?
When we're looking at the 4 blended competencies, know those as well. That's slide 14. Cognitive, technical, interpersonal, ethical, and legal. Okay? There will be a question what it might, and this is why I say know an example of promoting health. How would you promote health using the 4 blended competencies? So when I'm looking at cognitive, what does that mean? Making sure they understand the information, okay? How would I promote health using technical? Interpreter, perfect. Okay, maybe they need an iPad, maybe they need some additional information, an app, you know? If I'm teaching someone about diet and nutrition, maybe, you know, we look at FitnessPal or, you know, we do something together technically, okay? What about promoting health interpersonally? Using your resources, caring relationships, communication, finding out who their family and friends are, if they have anybody, okay? How would I promote health ethically and legally? You would work within your scope of practice. Okay? You have an ethical duty as a nurse to stay within that scope of practice. When I was a bedside nurse, I could not run into the emergency room and correct someone. Okay? As an advanced practice nurse, I can. So you stay within your legal boundaries of what license you're working under. So if I'm working at Kaiser, let's say, as a bedside nurse, I can't work as a nurse practitioner. I am not in that role. I'm not hired for that role. Okay, if I'm at Davis, I'm expected to be in that role. Okay, so just know what's legal and ethical and stay within that role. So I want you to be able to promote health, the aim, and I want you to be able to answer how you would accomplish that cognitively, technically, interpersonally, ethically, and legally. And then I want you to look at preventing illness, and I want you to think about how you're going to do that cognitively, technically. Like, just think about it. How would you do that as a nurse? Okay? How would you facilitate coping with disability or death ethically or legally? Yes?
Like the DNR.
Yeah. They have a legal document, a DNR that's signed. Is it signed by the doctor? Most of the time they're not. Yep.
The same with like postmortem care and documentation, once they pass something with them, that's like really big on the nurse.
Oh yeah. Have you've done that? Talk to us about how you helped.
We basically, because a lot of the times when someone dies and it's unexpected, the patient's family will be there and won't really know the process for like the technical part of like what we do with the body and what their responsibility with the body, and so we have to educate them on like we have a morgue, but you have to either have someone come pick them up or we can like handle that as well. And then also there's like a bunch of documents you have to fill out. Legally with the hospital, legally with the state, and then legally with the person who's taking care of the postmortem.
So family never plans on this.
Yeah.
They're not ready for this 99% of the time. And so, they're shocked, they're scared, there's a whole bunch of emotions going through it. And as the nurse, you have a legal and an ethical duty. You have to fill out paperwork for the hospital. You have to fill out paperwork for the state. Most counties make you call the coroner's office or the sheriff's department to find out if it's a coroner's case, if they've seen their physician within 30 days, if there was an expected death, et cetera, et cetera. So there's a lot of hoops as a bedside nurse that you have to jump through when your patient dies. But you're not alone when you're filling that paperwork out. You have your charge nurse. You have other experienced nurses on the floor who have done it before. Ask them. If you don't understand how to fill the paperwork out, that's okay. Have the nurse manager help you. Okay, and tell them, I don't know how to fill this out. I've never done this before. And they'll help you. Okay, so you gotta fax it here and then do this. And I mean, it's a whole thing. But, it's just to protect you guys as well. All right, so that is, all right, so you'll see question 3, hint, hint. Next page 15, slide 15. That gives you an example of what you'll see. All right, when we're looking at the nursing process, we talked about this yesterday. What is the nursing process? What are the 4 things? Assessment, planning, evaluation, implementation. Okay, so remember we assessed our patient, Joan, yesterday. We did our assessment on Joan. We came up with a plan, like what we want to do, like what we think is the right thing to do, right? We implemented the plan, so we said, I should put her on oxygen. Okay, I'm going to put her on oxygen. What did we do after we did an intervention? You always evaluate. Did it work or not? And what happens if it didn't work? Reassess. It's okay if it doesn't work. Okay? So we put her, she was on her nasal cannula, right? And we said, let's put her on a mask and see if that helps. So we put Joan on a mask. and let's say it's not helping Joan. We're gonna reassess why it's not helping her, okay? We're gonna look at Joan, we're gonna look at the tubing, we're gonna look at the oxygen to make sure it's on oxygen and not on air. You know, we're reassessing. When you walk by an IV pump that's beeping, we check the line, right? You're checking the IV, you're checking the tubing, you're checking the pump, you're checking to make sure it's plugged in. You know, there's many reasons why things don't work. So you always assess. So you assess your patient and your equipment. Okay? All right. So you will see a couple questions about the nursing process, and I'm going to give you, okay. The client's plan of care is created by the nurse using which guideline for nursing practice? Is it the nurse's social policy statement, the Nurse Practice Act, the ANA Standards of Nursing Practice, or the nursing process? Nursing process. So the patient's plan of care is created using the nursing process. Question? You okay?
Yeah, that's in the slides.
Yeah, because I'm lost.
That's not a slide question, that's a test question. Oops. Sorry.
You're very cool.
I cannot go to Vegas and play poker ever. So the patient's plan of care is created by the nurse utilizing the nursing process. Okay? All right. Good job. Okay. There was something about the values of caring and the professional nurse that was identified by the AACN, American Association of Colleges of Nursing. The values of caring, there's 3 of them.
It says 5 values here.
Where is
In the
that?
study guide.
In the study.
Oh no, there are 5 values of caring, but the AACN wants 3 of them. Actually, wait, what? Hang on. Hang on. I'm glad we're doing this together. This is great. We're gonna get rid of that. Hang on.
Get it away.
Oh, we're getting rid of that.
No, you need to know that. My question is written weird. Yeah, the AACN 5 values of caring. What are they?
That's such a good question. Thank you so much. I have no idea.
Perfect. Integrity, human dignity, autonomy. Why does promoting someone's autonomy make it seem like I care as a nurse? Planet cares about them, but do we want to promote their independence and then
Yes.
promote like
Yep.
them doing stuff? If their arms are not broken, can they brush their teeth?
Mm-hmm.
Yes. Can they hold their own urinal? Yes. Okay. Promote that. Promote as much independence as you can. Okay. You'll have those patients, and you will, who say, I can't hold the urinal right now. They'll want you to do stuff for them. But it's your job to kind of think outside the box and tell them, I'm here to help you, but I want to see how much you can do on your own.
Their autonomy.
Okay, promote that independence, because it does give them a sense of dignity, right? Think of the older patient that you're gonna take care of. When we're 16, we couldn't wait to drive, right? Get our license, get out of here, right? When we're 98 and get our license taken away and have to count on our family and friends and neighbors for everything, what do you think that does to their self-esteem? They literally give up. These patients give up, okay? Why? I don't have to do this anymore, you'll do it for me. And you will literally see the patient turn around if you promote their independence and autonomy and give them the confidence to do something. You'll see a behavior shift in these patients, and it's so nice to see it when you do, because you're like, it kind of makes you feel good as a nurse, okay? All right. Factors affecting health, slide 19.
Wait, so is there 3 or 5?
There is 5. Integrity, human dignity, autonomy, self-sacrifice. What does self-sacrifice mean as a nurse?
Prioritizing.
Yeah, it's kind of, I don't like explaining self-sacrifice because we've done it as nurses. I'm not going to go to the bathroom because I need to take care of my patient. I'm going to skip through my lunch because I need to take care of my patient. But what we really need to be doing as nurses is taking care of ourselves first before we take care of our patient. So that's kind of a hot topic.
I feel like wants and needs are like different though. Like you have to take care of your needs to be a good nurse, but like maybe you want to go sit down and your patient needs you right now and that's not necessarily.
Yeah, maybe I want to go to sleep and I don't want to be up working all night. Yeah. Yeah, you know, you're very true. Wants and needs are different, but you have to realize self-sacrifice is one of the things of nursing. That's one of the values.
What's the last one?
And sympathy, you know, we're compassionate. We act like we care. There will be those instances where you don't care, but you act like you care. Yes, Julia.
What slide are the 5 values of caring on?
I have to find those. I can't find it.
Yeah.
I'll let you know. That's from the textbook.
Okay.
Yeah. All right. So slide 19, factors affecting health. Factors that affect one's health. This is a fill in the blank question.
And
I
I
will
don't know, I
not
don't
give
have
you
the size
choices.
numbers.
Memorize 5 of them. 1, 2, 3, 4, 5, 6, 7, 8. There's 9 to choose from.
Factors that affect.
Factors affecting one's health.
Found it.
Slide 19. There's 9 of them. I'm only going to ask you to put down 5.
Okay.
It is chapter 1. It is slide 19.
Take picture with your, oh, river.
The question will read, name 5 factors that affect one's health. All you gotta do is just write down 5.
Where is it on here?
Where are we all the way down here? Hold on. I have no idea.
Yeah. Okay, so I'm at the ACCN and then just find.
Oh, factors that affect health and illness. Is that this one?
There you go. Yes. Good.
So I see that like lifestyle and environment are on one thing, so does lifestyle count as one and environment count as like a second one?
No.
Or-
That's 1.
Okay, so we'd have to write lifestyle and environment as one.
Pick 5 of those.
On the second page.
4 that affect health.
In the backside.
It does say 4 for the health and wellness ones.
Oh, 4 models? That's not a model.
No,
4 factors that affect health and illness.
That's a different chapter.
Oh,
Yeah. Okay, so age.
Get out your slides and highlight what's.
I have a question about the test itself. Overall question. Are the questions gonna be, like, as we see the questions, like, are they gonna be coming to us in the order of the chapters, or is it gonna be like all blended?
Blended. So next slide, slide 20. Healthy People 2030 Health Promotion Guidelines. Okay. What is the purpose of this? That's a fill-in. What is the, I don't want you to write down all of these. I want you to take this and tell me what it means to you. What is the purpose of having this? What's the purpose of having guidelines for the nurse?
Like, is there one specific answer you're looking for?
No, tell me what you, so looking at these guidelines, yeah, so attaining healthy and thriving lives, well-being, free preventable disease, disability, injury, and mature death, eliminate health disparities, create social, physical, economical environments, promote healthy development, engage leadership. What does that mean to you as a nurse?
It gives you goals to work towards.
It's holistic. Everything is centered around the patient. We want them healthy, thriving, well-being of preventable diseases, disability, injury, and premature death. We want to eliminate any healthcare disparities. Kids, yep. Yes. Yes, you're providing holistic care to the patient. It is patient-centered care. That's it. That's the whole purpose of having guidelines. You look after the patient, right? All right. All right, here's another one for you. You are the bedside nurse of a heart failure patient. List 3 ways you can maximize your patient's strengths and potentials. This is a fill in the blank. What are 3 things you can do as the nurse to maximize your patient's strengths and potentials? They have heart failure. So what can you do as the nurse?
Teach.
Educate them. Compassion. Promote independence. Do people die because they have heart failure? Yeah, but they also can live a long time. Okay?
You want like an example that goes with what we're educating them for?
Yeah, give me an example. I would educate them about healthy diet. You know, don't have the ham at Christmas and show up on Christmas Day in the emergency room full of fluid because you're in congestive heart failure, because you didn't watch your salt intake. Right? So low sodium, I'm going to promote a low sodium diet. I'm going to encourage independence and autonomy with my patient. Okay. You can monitor this. You can take the medicines. It doesn't mean they're not dying. They have heart failure. People live with heart failure. Okay. What is another thing that you guys can do to maximize the patient's strengths? We've educated them. We're promoting their independence. Include their support group. Find out who their family and friends are, neighbors, church members. You know, you can ask them, do you have anybody at home that supports you? You know, maybe their family lives 4 states away and they're here by themselves. Maybe they're an elderly person and their kids are all dead. And they live in a trailer off I-5 somewhere, down a dirt road. Okay. Who's their support system? Not the deer. I mean, maybe, but who is their support system? Okay, so I want you guys to pre-write that. Okay. A nurse is taking care of a patient recovering from hip surgery. Patient says they want I want a bath. Okay? But I want to get in the shower and bathe myself. Okay? They want to be independent. And you're like, they do require assistance to get in the shower. Okay? This is looking at Orum's self-care deficit theory. Know that. Let me find the slide. Yes.
The nurse practice hours, what about like definition
What?
like about the nurse practice hours? Isn't there a subject? What about like just the definition?
What does it do? What is it? Read it.
The Orm self-care deficit theory.
That was in the book,
Yeah, I think
but not on the slide. Basically, Orm's self-care theory deficit promotes patient independence. That's what it's doing, okay? So my test question, this patient was recovering from hip surgery. They expressed a desire to bathe independently, but they do require assistance to safely get in and out of the shower, okay? Looking at this Orem self-care theory deficit, what is your best action? Okay, I'm gonna give you guys some choices. Perform the entire bed bath for the patient to ensure safety. Nah, I'm gonna do it myself. We force them to do that, okay? Do you encourage the patient to attempt to bathe independently without support?
No.
Why? They need help, right? Do you restrict bathing until a patient can perform all of his activities alone?
No.
No. So you're going to assist the patient with tasks they cannot perform while promoting his independence, right? So he's had hip surgery, he wants to get up and bathe himself, but you know there's a step to get in the shower, right? So we're going to help him get in the shower. Once he's in the shower, does that mean he can't scrub himself?
No.
No. Here, I'm going to hand you some washcloths, and I'm going to give you some soap, and I'm going to be standing by if you need me, right? So we're still there promoting his safety, but we're allowing him to bathe himself independently. He'll probably need help drying off, right? Getting out of the shower, getting dressed. But Orem's theory talks about promoting your patient's independence and autonomy. That's what it is. Okay. When you promote their independence and autonomy, you're giving them the confidence to do something. Okay? Yeah, so you guys will see that. Okay. We're going to look at objective and subjective data. Okay, you guys make me so proud because my nurse practitioner students can't even get this right. So, you know. Okay, which source of knowledge is based on objective data? Okay, is it traditional knowledge, applied knowledge, authoritative knowledge, or scientific? Hint, hint. Okay.
you said which is objective.
Objective. Which source of knowledge is based on objective data? It is scientific, yes.
It's a little confusing between traditional and authoritative.
Okay.
Like, traditional is just, am I clarifying, it's just because people have been doing it that way. Authoritative is somebody has experience and that's why we're doing it that way. Or-
Authoritative would be I'm the doctor telling you to do it that way.
Right.
So traditional is like,
Passed down.
I don't want to like say this, but Darlene, back in the war we would do this,
Right.
right? So like traditional is kind of passed down like you said. Authoritative would be being told to do something because that's the way you do it. And it's not based on science, okay? All right. Yeah, so I would just briefly review about Orem's self-care theory deficit, only to just kind of reiterate to yourself about the independence and confidence and autonomy. Okay, just so you kind of have that in your head when you're reading these questions. You will see a few questions like that where the patient wants to do something and according to this theory, and then you're reading the answers and you're like, well, that's not promoting his independence and confidence. That's wrong. That's wrong. You're not going to see a question where two answers are right and you're going to have to choose. It's going to be really freaking obvious. Okay, what's right? I hate guessing names. I can't do that. All right. So objective data, that's based on scientific knowledge?
Yes.
You see it. It's measurable. No, seeing is subjective, right? No, subjective is what the patient tells you. So you see it. It's objective. It is measurable. Okay. Subjective data would be what they tell you. I feel dizzy. I'm having pain. So when they say I'm having pain, that's subjective, and then you want to quantify that and say, what is your pain level, 0 to 10? It now becomes objective, right? Because it's a measurable thing on a scale, 0 to 10. Okay?
Okay.
Yes?
Question on that. So like if someone says I feel nauseous, that's subjective, but
Yes.
if they're throwing up in front of you, that's.
Objective. Patient vomiting copious amounts.
But the patient's pain number that they give you is objective even though they're telling you.
If they walk in and they say, I'm having 10 out of 10 pain right now, it's subjective. Because you've not asked them a question to measure it. Because technically as the nurse, regardless what the patient tells you, I have 20 on 10 pain. You still have to get the scale out and be like, on a scale of 0 to 10, with 0 being none and 10 being a ton, where would you rate your pain? You have to measure it.
So it's the act of measuring that makes it.
And is it-
Measurable data.
And is it 0 to 10 or 1 to 10?
It's 0 to 10.
0
0 to 10. 0 is no pain. 10 is a ton of pain. That's kind of how I say it, 0 to 10. You know. All right. Okay. We know about subjective. You guys will know about how Nightingale influenced nursing. That's already on there. Okay. This nursing theory. Okay. Why are developmental theories important to the nursing practice? Do they describe how parts work together as a system? Do they define human adaptation to others and the environment? Okay. Do they explain the importance of legal and ethical care? Okay. Do they outline the process of human growth and development? Okay.
Can you repeat the question?
Yep.
I'm so sorry.
What are the developmental theories? Why are developmental theories important to the nursing process? And we all know the nursing process is assessment, planning, implementation, and evaluation. Why is a developmental theory important to this practice? Developmentally, it outlines the process of human growth and development, where they're at on the continuum. Okay. Okay. Which of the 4 concepts common in all nursing theories is the most important to nursing? Okay. 4 concepts: person, environment, health, and nursing. Okay. So when the chapter 2 on the study guide, why are developmental theories important to the nursing practice? Okay, because it outlines the process of human growth and development. We've answered that. 4 concepts common in nursing theory that influence and determine nursing practice. The 4 concepts are person, environment, health, and nursing. But which one is the most important
Person.
to nursing? It's person. Okay.
Person, environment, health, nursing. Which is the other 4 concepts the most important?
Everything's person-centered care. If you see anything that says person, that's the answer. Check it. Check that answer. Okay. All right. Evidence-based practice. I want you to read about evidence-based practice. Why do we care about evidence-based practice? What is it? What does it mean?
Based on scientific research.
Yeah. So we don't deliver medicine based on tradition, right? We're delivering it based on research. Okay, there's scientists that have studied this, that have studied numerous patients, that have come up with treatment algorithms that are proven to work. Sometimes they don't work. But based on the evidence, this is what we do. When I see a patient at Davis and I'm talking with them, they always make us cite where we found that research. I have read this article published by this physician team at Stanford. that said X, Y, and Z. It's either qualitative or quantitative. I mean, you're not there yet in your practice, but you will be. Looking at research articles, as a nurse, you are never gonna stop learning. You're always gonna be looking stuff up. Your patients are gonna come in with weird things that you're just like, what is that? You're gonna go home and Google it, read it, research it, put it in your file, so when you see it again, you could be like, oh, I read something about that. The whole bananas and latex allergies I thought was kind of off the wall when I first heard it, put it in my file, and then when I actually researched it, I was like, oh, it is a thing, okay?
If you're allergic to bananas, you're allergic to
That's not a test, but.
And then you get lots of little examples and scenarios where it makes it sound like within, on the floor, there's little mini experiments get run. Somebody reads something and brings it in, and then, is that a real thing?
Yeah. Oh yeah, oh yeah. I mean, you could have a patient on the floor that you're taking care of, let's say for like a week, and then, you know, you're just kind of like, why aren't they getting better? What's happening to them? And then you go home and you're curious, right? We're always thinking about our patients when we leave the job. We never leave it at work. We always take it home. And you'll read it, you'll research it, and you'll come into work and you'll be like, hey, I read an article about a study in Germany that they're injecting islet cells into livers to cure pancreatic diabetes. And then the doctor will be like, what? And then you can kind of help facilitate something for that patient. You actually can help them. Okay. All right. What's that? So evidence-based practice. Know that. Let me look at this slide here. The true-false questions you see in your PowerPoints are on there. Which of the following is a central theme in theoretic frameworks of nursing? This is slide 16, chapter 3. No, chapter 2, excuse me.
Are we done with chapter 1?
Yes, done with chapter 1.
Can I ask where we're at? You've mentioned the history and important people, but we only talked about Nightingale.
Mhm.
Should we be looking at the other people?
That's in the book that's on the slide.
Yeah, that's in the book.
But it's in the study guide.
Mm-hmm.
But do we need to know other people other than Nightingale?
Unless you want me to ask you about Claire Barton, and we can just go off about the Red Cross. But no.
We can do that another time.
Nice to know, don't need to know. I'm not gonna waste your time.
What was just knowing the framework of nursing theory?
Yeah, framework of nursing theory. Know how she kind of pioneered it. Know, like, you know. I'm not saying like she walked around with a lamp and, you know.
Right, here's a barrel.
Just basic. You know. She worked as a speakeasy before she was a nurse, you know. And I learned that when I was halfway through nursing school, and I was like, what? She's a prostitute? Oh my God. Freaked out.
Well, you were just on Jesus and the common, are we on common concepts and myths?
We are on, I'm changing the, hang on.
We're in chapter 2.
Chapter 2, slide 16. Okay, let's look at this one here. Okay? That'll be a test question, because guess what? It's a question on your PowerPoint. Which of the following is the central theme in theoretical frameworks of nursing?
The person receiving the care.
Yes. I like it when it's obvious.
Yes.
There's on a slide that was just framework of nursing theory, and it defined theory and said like we really like use what can be tested, and then I remember you said
This one?
No, I'm going
This
off
one.
of my notes, not off of
Okay.
the slides. But I just remember in class you said know that it can be tested.
Mm-hmm.
So just knowing that like any theory that we're using in healthcare has to be able to be tested.
Absolutely.
Okay.
Any theory that you're looking at has to be tested no matter what you do. Like when you're in science class and you come up with a hypothesis, right? Educated guess. You still have to test your theory. Does it work or not? Right? So you're making a plan for your patient using the nursing process. We do something, we implement it. Did it work or didn't work? Right? So we're testing that plan. Okay. When we're looking at primary, secondary, tertiary, and restorative health promotion, this is chapter 3.
We glaze over the 4 models of health and illness.
What are they?
Is that chapter?
That's chapter 3. Yeah, I'm skipping that. For now. Oh, no, we'll do it. We'll do it. We'll do both.
But it's on the exam.
Yep, no, it's on the exam. We'll do it.
Okay.
Okay. The 4 models of health and illness.
This is on chapter 3.
Chapter 3. The 4 models are what? I'm going to reword that. 4 factors that affect health and illness. Factors instead of
And
models.
is that health equity?
Basic human needs, slide 12. Human dimensions, self-concept, risk factors for illness or injury. Those are the 4 factors that affect human health and illness.
That's like further into the second.
Chapter 3 on the back page.
And just knowing those 4 things,
Yep.
but not necessarily. Self-concept,
Yeah. What do you think self-concept means? How would that affect health and illness? Yeah. What they understand about their health, right? All right. We will look at,
you were going over like primary, secondary, tertiary.
oh, yes. Okay, good. Here's a question for you guys. A camp nurse is educating a group of adolescent campers, okay, on the importance of regular physical exercise. What level of preventative care does this activity represent? Primary.
Can you say it one more time?
A camp nurse is educating a group of adolescent campers. She's giving them like a speech about exercise. What does that represent? Primary, secondary, tertiary, or restorative?
Primary.
Education is always primary.
We didn't talk about restorative in class. We got the tertiary and just talked about like you are like.
You won't see a restorative.
Okay.
No.
Okay.
Do you have those defined on a particular slide?
In the book.
Yeah, in the book.
They're on page 18 too, I
Page
think.
18.
Yeah.
Okay.
So primary is always education, and tertiary is like the outside resources and then the two.
And then secondary vaccines too, right?
Primary is vaccines. Rehab, tertiary center.
And then what's two and three?
Secondaries, when you, like testing for, I think, when you suspect that
Pressure, cholesterol.
Mammogram. Lab test.
mammogram, blood pressure. But it's interesting that vaccines is primary, I guess, with prevention.
Prevention. Prevention and education is primary.
It's annoying because it sounds.
Secondary is actually doing something.
Okay, so testing.
Testing, your health, your physical assessment on the patient.
And that's secondary?
That's secondary. Tertiary care would maybe have them working with physical and occupational therapy. You're rehabbing them.
It's like you're already sick, but you're trying to get better.
Yep. Yep. We kind of know what's wrong with you, so now we have to kind of implement, you know, the get out of bed 4 times a day. Mobility. All right. Okay. No, I'm not doing that. We talked about the human dimensions composing the whole person. There's 6 of them. Slide 16.
Physical, intellectual.
You will have to list all 6 of them. That is a fill in the blank.
Oh my goodness.
The human dimensions composing the whole person are emotional, physical, environmental,
Intellectual,
sociocultural,
spiritual.
intellectual, spiritual.
Do we have to put them in that order?
No, any
Okay,
order.
I'm like, I have them in totally different.
Yeah, whatever order you want.
Okay.
Yeah.
That's not Maslow's?
Mm-mm, that is
No.
not Maslow's.
Yeah.
It can interconnect. The big thing about Maslow's is, and Orms and all that, is promoting their confidence and their independence. This is what makes up the whole person. What makes me up? Spiritual, intellectual, physical. Like, what are the things that make me a whole person?
I'm just a little bit confused because you're saying know these terms because we have to write them out.
Uh-huh.
You previously said that any question that we had to type out we would know 2 words. Has that changed?
Yeah.
Yeah?
They changed. 'Cause
There are fill in the blanks.
Spiritual.
There are fill in the blank questions. You will be asked to fill in more than 1 or 2 words.
How picky are you on spelling?
I don't care about spelling.
Okay.
I can sound it out.
All right.
Okay? It can be in any order, I don't care, as long as it looks correct, I can get it. Okay? So you will be asked your question on the test. I'm going to give this to you.
Yeah.
Will say, list 6 of the human dimensions composing the whole person.
Okay,
You will have to list 6 of them in any order you want. I don't care about spelling. Just write it out. Okay? When we're looking at modifiable and non-modifiable risk factors, what are some examples of modifiable risk factors?
Yeah.
Lifestyle, exercise, diet, economic status. It can be, not for everybody. Drug use, modifiable, non-modifiable.
Modified.
Modifiable. Hypertension
Is it genetic?
Right? Could fall under both.
could fall under both, but is non-modifiable because it's genetic. Yeah.
So what, modifiable,
Modifiable is something you can change.
non-modifiable could be genetics too? Or no?
Non-modifiable can be genetics.
I think if I'm understanding correctly, non-modifiable is anything that there's no way, in any way you can change. Like, so you were born with it, like you have born with one.
You have a congenital
It could be
disease.
anything that you physically cannot change.
Yep.
And then modifiable is any way that you can, so I didn't realize blood pressure, so within, if you're looking at it, if it has a non-modifiable component, then it defaults to non-modifiable.
But what if you have genetic hypertension and you can take meds to lower your hypertension?
It's non-modifiable.
Because you can.
It's automatically a
If
risk
it's not
factor.
hypertension, you're just.
It's just non-modifiable. So like the doctor, all modifiable and non-modifiable things basically alert the healthcare team, what can be changed about this? Can I change the fact that so-and-so was born with diabetes? No, even though their sugar's controlled on metformin or insulin, that's a non-modifiable risk factor. Okay, if they develop hypertension, is that modifiable or non-modifiable?
Modifiable.
Modifiable. If they're born with it and it's genetic, it is non-modifiable. Okay?
So it's like,
Tricky.
for example, if they develop-
You're not gonna see anything like
So
that.
so like type 2 diabetes would fall under modifiable, type 1 would fall under non.
Non-modifiable.
What do you
If I'm
do
fat and
if
40 and I get diabetes, that could have been modifiable, right? I could have worked out, I could have had a diet, watched what I ate, stuff like that.
For the exam, you just want us to know when it can be changed
Give,
and when it can't.
give me an example of what a non-modifiable risk factor is and a modifiable. That's it. Okay. All right,
Are we gonna need to know the 6 major areas of the risk factors?
is that on here?
Oh, I don't know. It's on the slide though. Okay.
Okay, here you go. Another gimme for you. Which factor or factors is one of the general types of risk factors in regard to increasing an individual's chances for illness or injury? Yeah. Which factor or factors is one of the general types of risk factors? So I want you thinking about risk factors. That's your key thing. When you're reading these questions, really think of what the key words are, okay? Which factor is one of the general types of risk factors in regard to increasing an individual's chances for illness or injury? Is age a risk? Yes. Is the environment a risk? Is someone's lifestyle a risk? Is someone's gender a risk?
Yeah.
No. No, it's not.
No.
Is someone's sexual orientation make them at risk for injury? No. You can, but no. Like just like I'm not thinking like globally what's happening. You know what I mean? But like generally speaking, the old lady who's 98 years old who lives in the hoarder house, who smokes 12 packs a day. Those are all risk factors for increasing her injury. Okay? The old lady that has hip surgery that you discharged from the hospital with a walker who's got throw rugs all over the house, her environment, her age, that's risk for injury, right?
You're looking for one or a couple?
I'm looking for 3.
Okay.
And your answers will be age, environment, and lifestyle.
Is that like a filter one?
Nope,
Select all.
that's a select all that apply.
From the slides, there was the 6 major risk factors.
They're not options. The options I gave you are the ones that I just said. That's it. There's 5 listed on the test. I want 3 of them.
Yes,
And
ma'am.
the answer is age, environment, and lifestyle. No one better miss this question.
I don't remember.
All right. Okay. Let's talk about acute versus chronic illness. What is the difference between acute and chronic illness?
Acute is rapid onset.
Yes, what's chronic?
Long lasting.
Long
Happening for a while.
For a while. How long's a while?
6 months or longer.
Greater than 6 months. Okay? Greater than 6 months.
We're gonna use your reflective listening skills. It's like,
I love it. So, the difference or defining acute and chronic illness. Acute is sudden, rapid onset. Chronic illness is lasting more than 6 months. So does someone develop, if someone has COPD, chronic obstructive pulmonary disease, is that acute or chronic?
Chronic.
If they have pneumonia, is that acute or chronic?
Acute.
If they have diabetes, is that acute or chronic? Chronic. Unless they're newly, like right now
I'm
diagnosing
like, I
them
don't
with
know.
diabetes.
Do you know what
When
chapter
did they get
we're on?
diagnosed?
We are on chapter 3.
3 still? Okay.
Okay.
Yeah, this one.
Okay, here's another one for you guys. What is an example of a nursing activity that promotes secondary prevention as a level of preventative care? Okay. Is it conducting a smoking cessation
Oh,
class?
this is the blood pressure one.
Performing a blood pressure screening at a local mall? Performing range of
I've
motion
read that question a
exercises
few
on a
times.
bedridden patient? Good, you guys got it. Don't miss that one. All right.
Can you repeat the question real quick?
Yes.
Sorry.
It's one of the
What is
slides.
an example of a nursing activity that promotes secondary prevention as a level of preventative care?
Was this a pre-quiz?
And that is a
This is
quiz
a
on your
slide.
PowerPoint.
One of the questions on the slide.
What's, do you know what page it is?
You've
I
seen
don't
that
know.
one
It's
before.
in chapter 3, but I don't remember.
Okay.
Yeah, yeah, we've seen that one. It's an index card for me already.
Oh.
Looking at chapter 4 now.
Okay.
Let's go to chapter 4. All right. Maslow.
found it.
basic human needs hierarchy are which needs are the most basic? Which is stuttering. Okay, breathe. According to Maslow's basic human needs hierarchy, so the pyramid, right? Which needs are the most basic? Is it
Physiologic.
Physiologic. Good. Awesome. This is great. Oh yes. You'll see slide 5. That question's on there. Okay.
Beach.
Mhm.
I don't know if you answered this already, but when we were doing where our books are at, those quizzes that are free, for the chapter, would those be also an option on this exam? No? Okay. What was the question?
Like when you're doing your reading in the chapter and it gives you the questions to go
That's the
through.
10 you gotta go through or something?
Oh.
I didn't
The
get
end
the
one?
questions from that.
Or lecture quiz.
Yeah, 3 lecture quizzes, excuse me. No. Okay.
What about repeat?
I'm just having a little bit of an issue kind of differentiating self-esteem.
Oh.
Okay.
Like that question, you really want to be self-esteem, but it's self-actually.
What do we think that means?
They're inter.
Someone's self-esteem and their self-actualization. What do we think that means? What's the difference?
One is an action, one is the sense of self.
Nice job.
Can you repeat?
A nurse who focuses attention on the strengths and abilities of patients.
Strengths and abilities. What he can do. What he can do.
Versus like self-esteem is more of
I think I can do that. I feel strong. Maybe I can do that. Yeah, yeah.
You said one is an action and one is what?
Well, one, it's not that clear, but actualization requires action.
Yep.
And self-esteem, I guess like
Well, yeah. Yeah, that's exactly it. Actualization requires action. And when we think of strengths, we're going to require the patient to do something, right? Okay.
So would self-esteem be like, oh, my scar is healing? Or is that also
I got a zit on my face and I can't go to school today. Yeah. Self-esteem, right? My action would be self-actualization. I went to the drugstore to get some medicine for I did an action, right? Self-esteem. I can get out of bed by myself, and you're looking out and going, got no legs. Right?
For those, for the hierarchy, like there's 1, 2, 3, 4, 5. Do you want us to know the definitions and examples for all of them?
Yes. Look at Maslow's theory. Look at that pyramid. Be able to give me an example for each one. Know what it means. Okay? You'll see Maslow's all over your end of year test that you have to do too. Yeah. Before this class ends, I have I don't say a test outline, but a test outline. So we'll go over that. Because you guys take the test in December. And that's 2 months after our class.
Yeah.
So that we have a guideline. Okay. What is family-centered nursing care? What does that mean to you? Family-centered. Involving the family. So if you have a pediatric patient who's admitted on the ward, and we do family-centered rounds, right? So the whole team comes to the bedside, families encouraged to come and talk and to listen to what we say. I don't really like that, but we do it. Getting the family involved in the patient's plan of care. Because they matter too, even though patient is number one, we still have to think about if grandpa wants to go home and he's 54 and grandma's 98 and he's got a femur fracture, and so kind of have to think about the family too. family-centered care? Is she gonna be able to get him out of bed and bathe him and move him and pick him up off the ground if he falls? No. I did have a patient like that, by the way. Yeah. It was her. She called herself a jaguar. It was like, meow. Okay, we're good. This is good. Yeah. And she what did she? Oh, she would tell. I was working with a trauma surgeon who was like, kind of old, and she was like one of the first female trauma surgeons at our hospital, and she and this wife. Yeah, I remember them talking. And she goes, don't hate me because my husband's like 48 years younger than me. And then the trauma surgeon kind of like really got offensive to it. And I was like, why do you even care? But it was an interesting dynamic. So we had to think about family-centered care. So always think about that.
Is
Okay?
that on chapter 4 as well?
Yes.
For the family functions, 1, 2, 3, there's 5 different like family functions that do.
Family.
Yeah.
Oh.
Sorry,
Mhm.
yeah.
Mhm.
Well, structures and.
So,
And functions.
gimme, I'll give you a gimme. What is the major effect of a health crisis on a family structure? We kind of talked about this earlier, taking care of granddad with a stroke, right? What is the major effect of a health crisis on the family structure? Adaptation to stress, respect for family values, loss of individual identities, or change in role with the family members?
Change in role.
Change in role, right? I'm no longer granddaughter, I'm nurse. Okay?
Do you know what's
So a health crisis can impact the family structure. Okay? So the mother and son that live together,
I remember.
let's
it's 'cause I
say
remember
the
talking about
mom
it.
always takes care of the son and now the mom's had a stroke. And now the son has to take care of the mom. That's changing the dynamic of the family structure, right? So they have a role change now. So now the son is taking care of mom. Okay? Okay. When can you perform this basic family assessment? When you're kind of like doing your general survey and you're looking at the nursing process, when could you determine what's happening? During an interview, during the physical assessment, giving them a survey, or taking a poll?
During an
During an
interview?
Talk with them. Okay? Ask,
About the
oh,
family.
yeah, talk to them about your family. Tell me about your family. You know, tell me about your wife. That's not my wife, it's my girlfriend. It'll happen. Or whatever.
No, tell me about your daughter. It's not-
Tell me about your daughter. Oh, how pregnant is she? I'm not, I'm just fat. You know, like I got that one, so it's just embarrassing. But, you know,
When can you watch?
when do you perform a basic family assessment?
Oh.
It's during the interview. Right? You're actually talking with the family. Who do you have here with you? That's usually what I say. You know, let the patient introduce. You know, I don't want to assume or guess. Yeah. And you guys will have the girlfriend or the friend that's laying in bed with your patient and their significant other shows up. It happens.
Yes.
Quite entertaining. Okay. This one's a fun one. There's a question on your test that's going to ask you, it's going to give you 1, 2, 3, 4, 5 needs, basic human needs, okay? And you're going to have to look at these basic human needs and put them in order according to Maslow's hierarchy. So as long as you got the pyramid memorized, you'll be fine.
There are 5 examples. Okay, there's not examples.
So there's 5 needs. I basically scrambled them up. You need to put them in order.
For the pyramid, the bottom ones is like the most important, and the top is like technically the least. But we can list them. Like,
I think it's going to be.
Where did we end up agreeing on housing, or was that physiological or safety needs? Because I think that overloads.
It overlaps, but it's going to be a safety. Okay. So let's go over the order here. We're going to start with the most basic. Okay, looking at Maslow's, okay, the most basic need is a physiologic need. I want to go get a donut. Yeah, we all do. No. Okay. The next one is safety and security, followed by love and belonging, self-esteem, and self-actualization,
So would you want it in,
in that order.
okay, the bottom would be most important then.
What's a good love and belonging?
Yeah, love and belonging. You feel cared for. You know, you feel supported by your family or friends or community. Yep.
So the order would be from
Bottom to top.
activities to self-actualization?
Physiologic, safety and security, love and belonging, self-esteem, and self-actualization. Actualization. Okay? All right. Which nursing interventions promote maintain whole? Your question number 2, slide 12, the highest priority patient is on there.
So did you say it one more time?
Number 2, slide 12.
Yeah. If there's a question on your PowerPoint, it's on the test. Know that.
12?
Okay.
And which one is that? And which chapter? Chapter?
3. How long is this test? Is it 100 questions?
100 questions.
Okay.
12.
I got rid of a lot of the history stuff because I don't care about that. And what I want you to do
Question
is I
number
want you to
2?
read an example
This
and
one?
be able to prioritize
chapter
your
4.
patient's needs. Like you're using the nursing process. That's basically what it
Okay,
is.
that's why.
All right, let's talk about, let me count questions here. 1, 2, 3.
Which source for vital signs is our end source?
PowerPoint.
The questions for vital signs and just PowerPoint and the information that you gave us.
Yeah.
Or
You have 13 fill in the blanks. You have. Two. Okay, here you go. Here's a matching. You have 2 matchings. Okay, you'll have a table. It'll give you apnea, dyspnea, orthopnea, tachypnea, and you will have to match it with the definition.
Okay. Oh, we got that.
Okay. What is a positive orthostatic vital sign?
A change between. Oh.
What is it? How would you describe positive? Oh, they're positive orthostatics.
That means
Like a-
so change their blood
When they
pressure
go from
when they
down
get
to up.
orthos upright, right?
So if you were to report off to your doctor, if they go, I want you to do
Sitting, standing,
orthostatics on
laying,
them,
or sitting.
and that's the laying, sitting, standing blood pressure, right? And you have a change greater than 20 millimeters of mercury systolic, right? That's not on the test, but
Oh.
if you tell me that that patient has negative orthostatics, what does that mean?
They're fine. They don't have orthos.
Fine, no change.
Positive.
If I say they're positive orthostatics, that means there was a change, okay? When you check an orthostatic blood pressure and they are laying down and you sit them up, how long do you wait before checking that blood pressure?
3 minutes?
3 to 5 minutes.
Is that gonna
You
be a fill
have-
in the blank?
You have to, yes, you have to let them adjust,
Okay.
right? What happens if they're sitting on the side of the bed and you have them stand up and they're feeling a little woozy and you're kind of waiting and they're like, and they sit back down? Is that positive or negative orthostatic?
Positive.
Positive. And how would you describe that? Excellent. Positive orthostatics, dizziness while standing. Like quantify it. Tell me why it's positive. Because I didn't actually check their blood pressure at that time. They were just so dizzy. I sat them down. Okay. Okay. What are the name of the sounds that you hear when you auscultate a blood pressure?
Quarter. I can't pronounce it.
I can't spell it, but if you get it, then it'll be good.
Korofkov?
Korkov.
K-O-R.
Do I have to know how to spell it?
No.
K-O-R
I'll sound it out.
Oh, so it's kind of your fill in the blank.
Yep.
Oh.
Sound it out. Like, do a K, right like a doctor. Do a K in the line, you know. There you go.
What is the sound that you hear the first
Korkov.
beat when blood pressure?
Oh, the kickoff type of thing. Okay.
I don't know how to spell
It
that.
took me
I don't
3
even
years
know
in
how to
nursing school
pronounce
spell
it.
diarrhea, so
Yeah,
we're
I
all
can't.
good.
I still can't spell diarrhea.
Yeah, it takes me a while.
Still got 3 years there.
You got time. All right.
Korok.
Okay.
Korok.
I'm gonna give you guys a scenario. Okay. This is a post-operative. What is a post-operative patient?
Just had surgery.
Just had surgery. So a surgery or procedure, right? They're post-op. Okay. They are feeling restless and reporting shortness of breath. Okay. What is the first
Hypoxemia.
thing you do? Vital signs. Good. So you got some vitals. They don't have a temperature. Their blood pressure is 88/60. They're satting 84% on room air. Their heart rate's 130. Okay. So this is like a 2-part thing. It says, which action should your nurse take first? What would you do for this patient?
Oxygen. Air.
Would you give them an opioid?
No.
Would you leave them and call the doctor?
No.
Would you say, that's nice, I'll check you in 15?
No.
Or would you place them in high Fowler's position and apply oxygen?
Yes.
$5.
Yes,
Their blood pressure is low.
it's low.
We wouldn't have allergens.
Airway first. Airway first. ABC.
But we would give them oxygen, yeah.
I'd sit her up and place her in high Fowler's, and her pressure would drop even lower. So then I'd move to B. Her breathing looks good. Now I'm gonna move to C. I already you know what will happen with her if we place her in high Fowler's, but NCLEX, right? The computer says you need to do this. That's what you need to do. Because as soon as you sit her up with a low blood pressure, she's gonna pass out. So then we move on to B and C. But we've taken care of her airway, so we're good.
What was your O2 stat? Sorry.
84. Yeah. It's Joan, you know, that rancher Joan. We're gonna learn a lot about Joan in Med-Surg 3. She is chronically ill. She's like kind of a badass though. She's tough. I like that. All right. Okay. Can you name some things that increase your blood pressure? What might increase Joan's blood pressure?
Pain.
Pain, stress, anxiety, coffee, yeah. Drugs, uppers, yeah. Depends what drugs she's doing. Stress. Okay. Do you think that when you have a patient in the hospital and their home life might be contributing to some of their anxiety that they're in the hospital? What is one intervention that you could do as a nurse to help with that?
Not allow visitors.
Not all visitors. Social worker? You know? Is Angus the dog locked in the house? He's gonna piss everywhere by the time she gets home. Who's feeding Angus? Right? She's gonna get anxious about that. I know my grandma was so anxious about her dog. She didn't care what was going on. I think yeah. So stress and anxiety will increase your patient's blood pressure. Okay? And let's say Joan does not have a history of high blood pressure and she has a high blood pressure and she says she's feeling anxious. Ask her why she's feeling anxious. We're individualizing her care, right? We're using the nursing process. Why are you feeling anxious right now? So we're assessing it. My dog. Okay, my plan is I'm gonna call social worker and have them call animal control and get the dog. Okay? Okay. Okay. Fine crackles in the bases of the lungs may indicate what? Fluid. Fluid. Why is there crackles?
Because of the diffusion site, there's some sort of way, like, the process is being blocked. But
Yes, it's obstructing, so it's blocking, right? So it's just bubbling. Like, you know, that's like, I don't know if that's a correct example, but that's what's happening in my head. Okay, all right. Okay. How would you evaluate the range of motion on your patient? Yes.
Oh, like, they're all.
Lifting them arm. Can you ask them to move?
Mm-hmm.
Yeah. Okay.
That would be active.
It's just range of motion.
Okay.
Yeah. Yeah. Okay. You're palpating your patient's abdomen. So you're doing your assessment, you're palpating, and they grimace when you push on their belly. So they wince their face. Is that a vital sign, objective, or subjective?
Objective,
Why?
because it's something you see.
Good. Know the definition between hyperactive vowel sounds and hypoactive vowel sounds.
Yeah, what are the differences?
Hyperactive vowel sounds are high pitched, tinker, tinker, tinker. They sound like something, you know, like tink, 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 like water on a metal roof. That's kind of how it sounds. And they're every 3 to 5 seconds. Okay, kind of like rumbling in there. Okay. Hypoactive, like Joe says, you're at the bedside for 5 minutes and you maybe hear one gurgle. And then 5 minutes later you hear another gurgle. Okay. Hypoactive vowel sounds are a problem. Okay. If they're hyperactive, I'd kind of inquire as to why. You know, are they nausea and vomiting? Are they having diarrhea? Hyperactive vowel sounds, I'm not really worried about. Hypoactive, I am, or absent, I am.
Not movement.
There's no
activity,
movement,
there's
no activity,
yeah.
nothing's going on.
Yeah.
Usually patients, this is not on the test, but patients that undergo anesthesia, general anesthesia, your intestines are actually the first organ that fall asleep and the last to wake up. That's why we have to wait for return of bowel function, right? So we're always asking them, have you passed any gas? You know, if it's been a while, maybe we'll have them chew gum. You know, stimulate the salivary glands. You know, get things moving. That does help sometimes. Does ambulation help bowel function?
Yes.
Okay. Anyone have a toddler take a poop walk after dinner? Yeah? Okay. I used to do that with my kid. Okay. Don't tell her. Okay. Oh God, we had to.
I love that because it makes you names up in a family where you're like, hey, have you done a football?
Yeah.
Oh yeah. Or what's really bad is you know that her mother's a nurse when you take her to the doctor and she's like a teenager. Never tell her this. And they do an X-ray of her belly and they go, oh, she's FOS, and she goes, I'm not full of shit. I was mortified because that's what I use all the time at home. FOS. But yeah, that's she's fine. Okay, that's done. I'm making sure I'm getting all these. So nursing process is huge. You guys are gonna have a few questions where it's gonna ask you to do the nursing process. So assess, implement, plan, evaluation. Yep. Yep. I gave you guys a lot of questions, but it's okay. Well, let me count the true falses.
I love that you got excited about that.
Can you give us an example?
Of a true false?
No.
Of the nursing process question.
Oh, I did, with the one we just did with the blood card. with
Can we
the,
do another one?
Can we have
Question
them all?
45?
That one.
That one. Yeah, I'll do another one.
I think with the nursing process is such an emerging skill for us, that's like, it's harder for us to answer those questions than like the memorization
Yeah, I don't like that.
of facts. We're like, is it this, is it that, how do you apply your skills? At least I'm assuming other people's experience.
All right, there's 4 true false questions.
4?
That's it?
Sorry.
Oh.
The rest are multiple choice. Like,
Okay.
you have choices.
13 fill in the blank, 4 true and false, and the rest multiple choice.
Yeah, multiple choices, see?
I can't see.
I'm
Take off your
blind.
glasses.
I can't see that.
Okay, let's do another nursing process one.
You said you got rid of all the historical.
Not all of it, a majority of it. They were wanting me to ask like 20 questions on the history, and no, I don't care about Clara Barton and the Red Cross.
Ancient Greek civilization, early Christian period, 16th century.
Stop!
Have you taught it? Flashcards now. I was like, I don't know about this.
It's in the curriculum. I have to teach it.
But you don't care about that, right?
But it's nice to know. Do I need to know it?
Can you just go through her flashcards and just toss out the ones we don't
Which ones
need?
are garbage?
It's like 300.
And 10.
You're my
for
girl,
that, too.
just like me. That's
It's
what I
really
would do.
impressive.
295.
Yeah.
We've gone to town.
We have.
Yes. Goals,
More
man.
by asking those 4 questions.
I love it. But save them because you might need them at some point.
No.
All right,
No.
I don't even know that.
Or on the day of graduation, just bring me a basket. Here's your flashcard.
Yeah.
I'll be like, so sorry, guys. Yes, sir.
Seriously.
So is there gonna be any other date other than 2030 that we're gonna like wanna have in our head?
Healthy guidelines 2030. That's it. When I went to nursing school, it was 2000. Healthy guidelines 2000.
How'd we do?
Y2K. World's gonna end. I was working in the ER that night on New Year's Eve, 2000, and we were like all geared up, like we had like ton of extra staff, and like it was like a thing. I was gonna board off my door, and there was nothing going on. My husband got shot at though, which was interesting. He was on the ambulance. So story time. So he was on the ambulance, and it was when we were, we were married, yeah. And they went to this lady's house who was sick, and so they showed up and she came out with a rifle and started firing at them.
Oh my gosh.
And then, so they run back in the ambulance and he tells his partner, God, don't tell April this happened. So they end up on a call later on and they bring us a patient or whatever, and his partner goes, yeah, ask Jason how we were shot at earlier tonight. And I was like, so, can you tell me anything? And he goes,
Anything
no, I'm all,
interesting happened to you today?
any interesting patients you have? He goes, no. And I'm all, were you shot at earlier? And he goes, he kind of just looked at his partner and he's like, all right. Oh, here's a good one. Convection, radiation, evaporation,
Oh, I know that
and
one.
conduction.
I think.
Know that.
Yeah.
Uh-huh.
Okay.
Know those definitions.
Mm-hmm.
Okay. What is an example of convection?
Air fan.
Air fan in the room, right? What is an example of radiation?
Like no hat on your head.
Reflective listening, please.
Evaporation. What is evaporation? Water. Steam.
To gas.
Conduction. What is an example of conduction?
Cheer back on the body.
Ow.
Is this one going to be multiple choice or?
No. Just know the definition. What do you assess when you are assessing a peripheral pulse?
Rate, rhythm, quality.
Good. That's a fill in the blank. What do you assess when you assess a peripheral pulse? What are the 3 things you are assessing?
Rate,
Rate, rhythm, quality. Remember, is it regular or irregular? What's the number? right? Is it strong? How do we grade pulses?
0, 1, 2, 3.
0 plus 1 plus 2 plus 3
I thought it was 3 plus.
or 3 plus, depending on what facility you work at.
Okay.
I won't mark it wrong if it's plus 3 or 3 plus. Okay, but if you put 4, I will, because there's no such thing. 0 to 3. No. Matching. Matching. What's a matching one?
What about the radiation and the conduction? What's that? What kind is that one?
Examples.
You can just get it just as a practice.
Oh, I can't do that. I can't give you all of them. I want to, but okay.
Okay.
I go outside without a hat on,
Okay.
and my head gets cold.
Yeah.
Oh, okay. Radiation.
Why do we actually need to know the stuff for nursing, the
No.
radiation conduction?
Somebody comes in. Why do I need to know about Clara Barton? It doesn't help my nursing process.
Yeah.
I don't know.
Give us another nursing process. I think we
Yeah, like
need to know
example.
that because you want to know the physiological ways that your temperature is changed. So like if somebody's very sweaty, you should be thinking like that's gonna cool their body, you know that, right? Like if you.
So like a baby without a hat, like why we have them wear a hat for heat loss? I think that's why we need to know. But it's basically just need to know the broad terms, like what does it mean? Like, could they get cold, hyperthermic or hypothermic when they're like sweaty and soaking wet in bed? Like we just pulled some body out of the river, we did CPR, we got them back, they're soaking wet. Or no, someone crashed their car on a rainy night. We brought them into the ER, they still have their clothes on, they're soaking wet. Could they get hypothermic? And why could they be hypothermic? Because of heat loss, right? And what's that heat loss called when they're soaking wet clothes on?
Your notes, yes.
Conduction?
Conductive. The cold plastic backboard underneath them. Okay. All right.
Rainy nights always.
Let me find a process question.
April,
Yes.
just so I'm aware that like nursing, when you ask a question, the answer people mumble. That's what I'm saying. Like,
Oh, just repeat it?
Yeah.
Excellent, I will do that. Okay. Okay, let's make one up. Nursing process question. We have a 54-year-old male who comes into the emergency room with chest pain that started an hour ago. His vital signs, blood pressure 130/70, heart rate at 89, respirations are 20, his oxygen saturation is 96, temperature is 36.5 orally, remember it's in Celsius. Pain is 8 out of 10, non-radiating, it's just in the middle of his chest. What do you do next? You've done his vital signs?
Seems like all the vital signs are normal.
Vital signs are normal,
Yeah.
but he has pain, 8 out of 10 chest pain. What action should the nurse take first? And you guys will see this a lot, like moving through the program. It's going to be a scenario, and then it's going to say, which action should the nurse take first? So
I want to know what makes it come and go, because isn't that the get?
we've already done the pain, so you've already kind of assessed it, and you asked the OPQRST.
Can we give pain medications?
Would you give him pain medicine?
Yes.
Would you notify the healthcare provider? Would you give him a bite to eat? Or would you put him on the cardiac monitor?
Cardiac monitor.
Yep. So it's examples like that, not on the test.
Back to
But
like ABC, right?
A, B, C. So his airway's fine, right? His breathing is fine. Circulatory, his blood pressure is fine, but he does have chest pain, so something might be happening. So when you have a list of examples, what I want you to do is look at those and read them and go, that doesn't make sense. That doesn't make sense. Find the thing that makes the most sense to you and what's urgent about that. Right? So like Jones was putting her on oxygen and changing her to a mask. This guy who was mowing his lawn is, let's get him on an EKG. Let's look at his heart. Okay? So just look at when it says which action should the nurse take first, read all of them and figure out what do I need to do first? Prioritize their care.
Priorities pain, then let the physician know.
Can you remind me what the OPQRS team?
So onset, when did the pain start? Okay. What were you doing when the pain started? Okay. What was he doing? P, what does P stand for? Provocation. Does anything make it better or worse? I kept running. My wife does when she yells at me. Okay. OPQTR. Radiation. Does it move anywhere?
Wait, you missed Q.
Oh, Q. Quality. How would you describe your pain? My biggest pet peeve is when you give them choices. Sharp, stabbing, dull.
Let them do it.
Let them talk. Do not give them choices. It's
Yeah.
subjective. It's subjective.
Yeah.
Pain assessment, when you're asking them questions to describe it, that's subjective. That's the patient describing it to you. You don't want to put words in their mouth. So how would you describe it? And they'll be like, an elephant is sitting on my chest, or I can't. Patient unable to describe pain is what you write. Don't say, is it sharp? Is it stabby? Is it dull? Like I can't stand that. Sorry, pet peeve of mine.
Radiation.
Radiation, does it move anywhere? Does it go into your shoulder? You know? Where is the pain? They'll just be like, oh, it's just right here, it's right here. And so if they're pointing at their whole chest or rubbing their chest, you can be like, can you take your finger? And I look at them. Take one finger and I want you to point to your pain and see if they can like pinpoint where it is. Okay? What's next? OPQRS. Severity. That's when you do your scale. On a scale of 0 to 10, with 0 being no pain and 10 being, I say, a ton of pain, what number would you give me? And sometimes I have the pain scale, and I will show them on the scale, where are you at? You know, they do it in triage in the ER all the time now. They pull the computer up and go, where's smiley face you at? You just point to whatever. Okay. What if he's unable to give me a number? Can I use the face scale?
Mm-hmm.
Okay. Am I allowed to like judge his face by the scale? Yeah. I can look, like if he can't quantify a number, but he looks like he's crying, I'm gonna find the guy who's crying and be like, a patient crying. Okay. What comes next?
T.
Time. When did it start? How long does it last? Does it come and go? That's all you ask.
So for onset, would that be like when it started, like what were you doing, and then time be like how long ago?
How long ago?
Okay.
So what were you doing when the pain started? What do you do if the patient says, I woke up like this? How would you document that?
Onset today.
Patient reports, I woke up with chest pain. So the chest pain was severe enough to wake him up from sleep, right? And then for time, you would handwrite, patient woke up with chest pain. So, and patient woke up at 3 o'clock this morning. So then, you can kind of quantify how long this pain has lasted for the patient.
Okay.
Right? All right, so you know about the lung sound. What's an irregular heart rhythm called? Okay. A regular heart rhythm is called dysrhythmia. Let me look and see if there's anything else. I have some more questions I can give you. Take a break, you can take a break.
Irregular.
Actually, we can go. Mm. Yeah, we are done.
I thought we had more practice questions.
I think we have about another 50 questions we can go over.
Yeah, we still have about an.
I have another.
This class is not over
Yes.
till 12:30.
We don't really talk at all about like oxygenation. It wasn't super on the study guide either.
There's a reason for that, I guess.
It's not on there.
Because we have a separate quiz on that.
Because you have a quiz on that the following week.
That's why I asked.
I know, I do remember you asking her that,
So,
and she said
so
yes.
no, on oxygenation, the multiple choice question, the scenario question I gave you had some oxygenation on it, right?
Yeah.
The patient's oxygen stat was 89. So you have to know, like,
Yeah, but they wanted me to ask.
I'm not gonna ask you what a nasal cannula is, incentive spirometer. I'm not gonna ask you what that is. But you have to know what, Joan, who had a nasal cannula on that wasn't working properly or wasn't strong enough, what else would you do? So you have to know that like her oxygen saturation was not good enough, so I'm gonna put her on this. So you kind of have to know, but I'm not gonna ask you specific numbers. Yes?
Regular heart rhythm to sinus, so that irregular is
Yes, I have.
Dysrhythmia.
I haven't quite figured out like what my like
I know.
process is.
But the way that
also wrong.
But the way that it will be worded on NCLEX and all your predictor tests is dysrhythmia. In real life in the hospital, we call it an arrhythmia.
Sorry, so what's the difference between arrhythmia and dysrhythmia?
Dysrhythmia, they're synonymously the same thing.
Okay.
Okay? So dysrhythmia is an irregular rhythm. Yeah. In the hospital, when you're working like as a nurse, they're not gonna call it a dysrhythmia.
Yeah.
They'll call it a rhythm. They'll call it a rhythm.
Means difficulty.
Difficulty. Different rhythm. It's not normal. But go through the questions that you see that give you like scenarios. Be prepared to have the scenario and have it say, which action do you take first? Okay, there are nursing process questions. Okay, so if you know your head to toe assessment, you know what we do first, airway, breathing, circulation, then you'll be able to answer the question.
If I don't lose tidal volume, vital capacity.
God, no. No.
Forget about it.
When you get to Med-Surg 3, we'll have a lot of fun with that.
For the
Vent
You
stuff.
did say something about end tidal volume.
So end tidal, what's a normal end tidal? 35 to 45.
Do you want that for this exam or
Yes.
just for the clip?
Okay, can you repeat
So
that?
when you are looking at, okay, when you have a scenario, I give you a scenario. It's gonna give you vital signs. One of those might be an end tidal. I might give you a lot of information. Blood pressure, heart rate, a SAT, maybe I'll give you an end tidal. And it'll ask, which intervention do you do first? So if your patient's end tidal is 20, they are acidotic, what are we gonna do? Their blood pressure's fine. Maybe oxygen? Right.
And then what did you say the normal title is?
35, 45.
The only thing I want, sick or not sick, right? Is it regular or irregular? That's it. Don't like. Don't throw away them, keep them.
Yeah, keep it for next week.
You'll need them for next week.